Now we will be learning about inguinal hernia and the anatomical basis of understanding that what are those issues where people are suffering from this problem. Before going to the inguinal hernia details, we need to understand what is a hernia. Hernia is protrusion of an organ or part of an organ from one body cavity to another body cavity through an opening which is abnormal to it. This opening is not made for this. How? For example, the esophagus passes through the opening in the diaphragm, a specific opening which is located where? At the 10th thoracic vertebral level, and then it reaches to the abdomen, and there it becomes the stomach. But if the stomach passes through same opening or another opening and reaches to the thoracic cavity, now we will not call it a normal case, we will call it as a hernia. So, protrusion of an organ or a part of an organ from an opening which is abnormal to it. That's the key word. So now to understand what hernia is and what happens. So now first of all, I'm showing you this picture. Before going into the details, it is highly recommended you should have good understanding of the anterior abdominal wall. I have my own video which has been recorded for anterior abdominal wall, and then also you need to have understanding of descent of the testes, the developmental pathway. So these are highly recommended things before understanding that how and what happens during an inguinal hernia. So now, what are we looking at? We are looking at partially a pelvis. It's not complete because it's not showing all the bones of the pelvis. You're looking at the pubic bone, pubic symphysis. This is where we can see these superior and inferior rami of the pubis. Some part of the ischium is in the picture. You can see the upper femur with the head, neck and the trochanters. You can see some contribution from the ilium part, but it's not complete. And then after that, a muscle on one side, the bone and this ligament has been shown. You can color match. This is inguinal ligament. We'll talk about it. Now you're looking at this white and green structure. What is that? This is one of the abdominal wall muscle, anterior abdominal wall muscle. And we all know the muscles in my anterior abdominal wall, they are named according to their direction of their fibers. And this muscle, it's arranged obliquely. You can see these dotted lines in this green and this white frame. So this is my external oblique muscle, and this white part is the aponeurotic part of my external oblique. And this green area is indicative of the fleshy part, the muscle part. So this muscle becomes aponeurotic. What is an aponeurosis? Aponeurosis is a very strong structure, and it is being said aponeurosis is a flattened tendon sheet. So it's as strong as a muscle, as strong as a tendon. And then we are looking at this inguinal ligament. What is this inguinal ligament? This external oblique muscle, when it comes down towards the anterior superior iliac spine and pubic tubercle, it's attached in those two bony landmarks. And the remaining part of my external oblique muscle, aponeurosis, it's free, it's not attached. So it folds on itself. And this lower free part of my aponeurosis of external oblique, which is attached from anterior superior iliac spine to pubic tubercle, we call it inguinal ligament. And you can see this inguinal ligament. After getting attached to these two bony surfaces, then this ligament, it reflects. And this reflected part here, which is my half moon like, so we call it lacunar ligament, and then it's been attached on the pectinate line. So this is the pectineal ligament, and it is also famous with the name of the Cooper's ligament. So my inguinal ligament has so many components. So we are looking at the inguinal ligament, lacunar ligament, and Cooper's ligament. Guys, these terminologies are very essential when you are understanding the mechanism, how these inguinal hernia and how our different changes are occurring within the inguinal region. Now coming to this tube-like structure, which has been shown here, and it's not shown here because the muscle has not been shown here. So this tube-like structure, that is known as the inguinal canal. It's a tube, it's a pathway. You cannot see this tube if you open up the skin. This is inside, but you can see a hole here in the epineuritis of external oblique, and this hole we call it superficial inguinal ring because it belongs to an inguinal canal. And there is a dotted opening, and that is called deep inguinal ring. Deep inguinal ring is not visible from outside. To see the deep inguinal ring, you have to enter into the abdominal cavity either through a direct incision or with the help of a laparoscope. So now, and this inguinal canal is the mainstay for understanding of the inguinal hernia. So let's look at it. Now there is another inguinal canal has been shown. So we have inguinal canal on both the sides, and it is there in both the genders. And that is my right. This was the right and this is the left inguinal canal. So now, for the purpose of understanding of the inguinal hernia, we have to pull this inguinal canal out of the body. So it is being taken out, and now it's just a tube with two open ends. So we have to transform into a rectangular. And now let's explore this rectangular. So now this is my same inguinal canal, and we have just transformed this tube into a rectangular with all the walls. Going further, look at it. So now this is what the deep ring, it has been represented like that. And which part of my anterior abdominal wall muscle is contributing in making, where is this opening? That is in the fascia transversalis. This is the deep inguinal ring, and its location is in the fascia transversalis. And then if this was the deep ring, so this will be my superficial ring. And where is this located? This is located in the aponeurotic part of my external oblique muscle. After that, this is the floor of my inguinal canal, and who makes it? That is, we have already talked about the aponeurosis of external oblique. When it was named as inguinal ligament, it folds inwards. So this lower folded part, that makes the floor. So aponeurosis of external oblique contribute in making the floor of my inguinal canal. And then this is the posterior wall, and this posterior wall is contributed by certain structures. And what are these structures? We have a term used as conjoint tendon, and that is located medially. Now first we need to understand what is conjoint tendon. The lower arching fibers of my internal oblique and transversus abdominis, they arches over, and medially they are contributing in making the posterior wall, and laterally we have fascia transversalis. So these two structures, they contribute in making the posterior wall of my inguinal canal. Then this comes the roof, and roof is made by the arching fibers of my internal oblique and the transversus abdominis. And now anteriorly we have the aponeurosis of external oblique muscle. So external oblique muscle is instrumental. It makes the anterior wall as well as it makes the floor of my inguinal canal. So now, why we need this tube? Something has to get out of my abdomen. And what is this structure which is coming out? Guys, this is a tube. And this tube, where is attached? Who is being present at this end of this tube? We have the testes, which is attached at this end of the tube. And this end of the tube, it goes backwards and it has to be connected with the urethra. We'll talk about it, what job it performs. Primarily, this tube is the one, this is the tube which transmits the sperm, which has been made within the sperm, which has been made within the testes, because the spermatogenesis is occurring within the testes. After the sperm has been made, they travel through this tube, they pass through all the way, they come inside, and then this tube is going behind the urinary bladder, where it is connected to a sac-like structure called as seminal vesicle, and this seminal vesicle is a place where it can be stored, and from these seminal vesicles there are ducts. These are known as the ejaculatory ducts, and these ejaculatory ducts, they are opening where they are opening in the prostatic part of my urethra, and then at the time of ejaculation, the prostatic fluid along with the sperm, all of them, they have been pushed out with the name of semen. So the sperm is traveling and then they have to reach to their destination. And then this is the tube which passes through that. And this pathway is not only made for this tube, because this tube is attached to the testes, and testis was exiting out of the abdominal cavity, and this pathway has been used. So this is the supply line, and then my testis is a living organ, so there is an artery and a vein which are connected to the testis for its well-being. So what is this artery and what is this vein? You are looking at the testicular artery, and then the vein is the testicular vein. Testicular artery, from where it's coming, it's a direct branch from my abdominal aorta for both right and left side. And testicular vein, the right testicular vein, it goes and drains into inferior vena cava. But the left testicular vein, it does not open in the inferior vena cava, rather it opens in the left renal vein. And these testicular vein opening in the left renal vein, it explains a lot about certain people who suffer from a clinical condition famous with the name of varicocele, and that is the scrotal sac feel like as if a bag of worms. What is that? These are the dilated veins. There are some obstruction, and that is connected to some kind of infertility. I'm not talking about those details, otherwise there's a lot to talk about that I'll be explaining in some other video. So these are the three structures, and then we had a nerve. We need a nerve to pass through it, and this is the nerve. What is this nerve? This nerve is coming from my lumbar plexus. From the lumbar plexus we have a branch which is named as the genitofemoral nerve, and this genitofemoral nerve, it splits into two branches. It splits in two, and one of them which has been passing through the deep ring, then the canal, and then exiting out at the superficial ring. This one is my genital branch of genitofemoral nerve. Remember, the femoral nerve is not that famous femoral nerve which is supplying the extensors of my thigh. That is a different femoral nerve. This is another one. So my genitofemoral nerve, it splits in two, and its genital branch, it passes through this. Now after that, there is another nerve, but it does not enter, worth noting point, it does not enter the deep ring. Rather, it pierces the roof, and then it runs in the canal, and then it exits out through the superficial ring. Now, what happens? This testis and all its supplies, so all this cluster of the structure, collectively we give them a name and we call them spermatic cord. And now when the testis and its spermatic cord, they passes through, they are exiting out of the abdominal cavity through the deep ring, then to the canal, and then through the superficial ring, and then to the final destination, which is the scrotum. Why that is happening, we'll be talking about it shortly. So whatsoever layer of the anterior abdominal wall muscle, it pierces, it passes, it doesn't pierce them. It rather pulls, it drags a wrap of that. As you can see, this is the wrap which has been driven from my aponeurosis of the external oblique, and we call it now external spermatic fascia. Similarly, the other wraps has been taken by this testis during its descent, and understanding of the descent of the testis is one of the integral part for the understanding of the inguinal hernia, and a very pertinent type of inguinal hernia, that is indirect hernia, and what are the consequences which are connected to that. Now question is, why testis has to get out of the abdominal cavity? Within the abdominal cavity, we all know the temperature is very high, and if the testis stays within the abdominal cavity, the process of spermatogenesis will fail, and the person cannot be a father. So for that sense, the testis has to be get out of the abdominal cavity, and for the testis a special sac has been created, and that is famous with the name of scrotum. And this scrotum is the place, and primarily due to the temperature, high temperature, the testis has to get out. That's why when a male child is born, it's very important that at the first time of his examination, just after his birth, our pediatrician should feel for the presence of the testes within the scrotal sac. And if the sacs are empty or malformed, some kind of intervention is required and it is mandatory. Now, this point I have already discussed, that the anterior wall and floor of the inguinal canal are both formed by the external oblique aponeurosis. So now let's look at the descent of the testis. A very critical time, approx near to the 26th week. What happens? So to understand that, let's draw. And let's label it first. This you are looking at the rectus abdominis muscle, and there it's attached to my pubic symphysis, one of the muscle of my anterior abdominal wall. And then this muscle is enclosed by the facial sheets, the aponeurotic sheets, and these are called anterior and posterior rectus sheets because they belong to the rectus muscle. These are the anterior and posterior component of my rectus sheet, and this all together, these coverings and the rectus abdominis together, they are the muscles of the anterior abdominal wall. This is the posterior abdominal wall, and this is the pubic symphysis, and that's the rectum. And now inside, can you see this yellow hanging sac-like structure? This is nothing but the fascia transversalis. And inside of that, there is another lining, and that is a peritoneal lining, and this is my parietal peritoneum. And this is the testes, which is present where? At the posterior abdominal wall. In the females, ovaries are also here, but when they descend, their destiny ends when they reach to the pelvis. They need not to get out of the body. So now this testis, which is there originally, it has to get down to reach to its destination. And what is this destination? That is the scrotal sac or the scrotum. And now this is the gateway which has been used for this testis to get out of the abdominal cavity and to reach to its final destination. And this is what? This is the inguinal canal, and it has an inner opening. We call it as the deep inguinal ring, and it has a superficial opening, and it's known as the superficial inguinal ring. Now this structure, this dotted line, is representing a very important structure, and this is known as gubernaculum. Let's use it as the tracker, the pathway. So now this is my gubernaculum, and you can see now testis has started its descent. Now you should pay attention at this point, because with the descent of testis, this peritoneum will be following it. The parietal layer of the peritoneum. So you can see that it is breached from there, and there is a loop of parietal peritoneum, blind loop, that is following this testis, which is descending downwards towards its final place. And this is given the name of process vaginalis. Now this testis has reached to the deep ring in the canal and bottom to its scrotum. And this process vaginalis, first this gubernaculum disappears and process vaginalis follows it all the way down, and it is going by the side of this testis. Now question, if a child born with this open channel, very easy, content of the abdominal cavity can pass, and there are so many clinical conditions. I'm not talking about those at the moment. But this doesn't happen. After this journey is complete, this has to be cordoned off. This has to be closed from this location. So my process vaginalis, which has followed all the way down to the scrotum, when it was following this testis, which was going down, so it closes up. So if you can see that, and now this gubernaculum, it was acting as an anchor, and it fixed this testis with the scrotal wall, and now we call it scrotal ligament. And look at it on the other side. This process vaginalis starts disappearing. And now it has been closed. The rent has been closed. So what will happen with this process vaginalis? This process vaginalis, will it disappear? No. It will persist. But just a small part, and that surrounds my testes, not completely but one side, and it remains a sac-like structure, and this is being given the name of tunica vaginalis. I hope we understand. The gubernaculum, that turns to be the scrotal ligament, and the process vaginalis, that becomes the tunica vaginalis, and the testis has reached to its final destination. So there was a pathway. So if there was a pathway, normally it is closed. But if, for reasons, there are so many reasons, if there is some weakness, so there is a fair enough chance that the content of my abdominal cavity can pass through this duct system and can reach down to the scrotum. And once this happens, it happens a lot. Once this happens, then we call it, oh, someone is suffering from a inguinal hernia. And the treatment for hernias is surgery. It's not any tab or any injection will take care of the things. We need primarily some surgical intervention. And this is all about we are repairing a weakness. So now let's review the thing which we have learned so far. We have learned the descent of the testes. We have learned the concept of the inguinal canal and different epineuritic parts of my anterior abdominal wall muscles, how they contribute. So now we are looking at partially the pubic bone, the ischium, and the proximal part of my femur. Ilium is not being shown here because we don't need it at the moment. We are looking at the pubic tubercle, and this is the medial side, deep, superficial. This is my orientation. And my two hip bones, coxal bones, they are connected anteriorly by this, at this location, symphysis pubis. And there is this green structure, band-like structure, we call it linea alba. A very important and very strong structure, very thick, very strong above the umbilicus, but below the umbilicus it's little weak. And now, what are you looking at? This band-like structure. This is what? This is my fascia transversalis. And in this fascia transversalis, now what you're looking at, who's coming out first? That is my vas deferens. We have talked about it. This is my testicular artery, testicular vein, and then the genital branch of the genitofemoral nerve. So they are passing through this fascia transversalis. There is an opening, and they are connected together when they get all their wraps, and to this other end, what has been connected is the testes. So now they all are entering, and when they are entering along with this nerve, so they drag a wrap. Testis and these structures, they take a wrap at the location, the deep ring, and this wrap is this structure is what? This is the wrap which they have dragged from this fascia transversalis. So this is the part of my fascia transversalis which is covering, and it is coming along, and that is given the name. It is called as internal spermatic fascia. After that, another muscle layer, aponeurosis, has been on the way, and this is my transversus abdominis muscle, but you can see that it has a defect, so it does not participate in making of my inguinal canal at this location. So there is a gap, so it don't provide any wrap. So this progressing down testis and its supplies, they can pass without dragging any component from my transversus abdominis muscle. And after that, there is another aponeurosis of a muscle which is on their way, and now this is obstructing the way. Who's that? This is my internal oblique muscle. So now they pass through that and they take a wrap of this internal oblique muscle. So now how many wraps? The testis has been getting a wrap from the fascia transversalis. That wrap was called as internal spermatic fascia. Now it drags another wrap from my internal oblique muscle, and this will be called as cremastric fascia. After that, my external oblique aponeurosis is on the way, and now it will also drag a wrap from here, and there is a defect in that, and through this defect that will be called as my superficial ring, and then it will be passing out of it. So superficial ring, and it drags a wrap from there, and now we call this one as external spermatic fascia. And now the distance between my superficial ring and deep ring, this whole channel, we call it inguinal canal. And then this is my testis, has not been shown in this image, so you can see this spermatic cord, and this spermatic cord has all the wraps. Wraps from my fascia transversalis, wrap from my internal oblique, and then it will be having a wrap from my external oblique. So this, if you look at internally, this spermatic cord, you can see that it's a complete tubular structure, and you can see there are multiple layers. Now we are looking at this nerve, which we have already talked about that. It does not follow the deep ring, but it pierces the roof and then it comes out of the superficial ring, and that is my ilio-inguinal nerve. Now, what is this green structure? If there is a weakness and if there is rise in intra-abdominal pressure, loop of intestine or any other part of the abdominal content may travel, and this green color is indicative of a hernia. And if a hernia passes through the deep ring, the canal, and the superficial ring, we call it indirect inguinal hernia. And usually this hernia is most commonly seen in early stage of life. It doesn't mean that people in old age they cannot have a indirect hernia. They can have. And one of the very diagnostic point, and that we can establish only when we are exploring a hernia surgically. We have a very important vessel which runs here at this location, and that is my inferior epigastric vessels. So if this hernia passes lateral to that inferior epigastric vessel, now this is the time we call it indirect type of hernia. And if a hernia which passes medial to that inferior epigastric vessels, we call that hernia as a direct inguinal hernia. Hernia is all about a weakness. So now we have to push all this thing back, and then we have to repair the weakness. So we have to close the rent, and then we have to provide some external strength by the help of a mesh or some other surgical intervention. There are so many procedures described, established in practice since ages, and they have their good results, but there are other factors as well. So this is what you need to understand, how this indirect inguinal hernia continues its journey. It passes through the deep ring, it takes the canal, exit out of the superficial ring, but the main landmark is the spermatic cord. This hernia, it is laterally located to my inferior epigastric vessel. That's one of the diagnostic point. And then this is my external spermatic fascia which wraps around. I hope we are clear with this concept. Now the direct inguinal hernia. What happens? It does not follow the deep ring. It rather comes in this location. And what this location is all about? So here I have the inferior epigastric vessel. So they are making a boundary. And here I have the rectus abdominis muscle. And the base is what? The inguinal ligament. So a triangle is being formed. And this triangle, I have told you its boundaries. The inferior epigastric vessels laterally, the rectus abdominis muscle medially, and the floor is made by my inguinal ligament. And this triangle is famous with the name of Hasselbeck triangle. So any hernia which passes through this area, this is called Hasselbeck triangle, and which comes out of this, and then it enters in the canal, passes through the superficial ring, reach to the scrotum. That is a direct inguinal hernia. For femoral hernia, that's a different thing. But remember, the femoral sheath also being connected to my fascia transversalis. Now we are looking at the inferior epigastric vessels. Guys, these inferior epigastric vessels are serving as a very clinically relevant, important landmark while we are talking about the inguinal hernias. But before, let me orient you with this part of the cadaver which we are looking at. This is my anterior superior iliac spine. This is where we have the pubic symphysis a little bit down, and this is the left side. And now, as we have said, this is what? The inferior epigastric vessel, and they are going towards behind my rectus abdominis muscle. Now these inferior epigastric vessels, and just lateral to them you can see this deep ring, and you can see going inside this deep ring are the vas deferens and the testicular vessels. Now, any hernia which is lateral to my inferior epigastric vessel, this hernia will be known as indirect inguinal hernia. But a hernia which passes medial to these inferior epigastric vessels from this location, that is known as the direct inguinal hernia. And if you pay attention, you can see there is a triangle which has been formed here. Can you see a triangle formation here? Guys, this is the base of that triangle. And who contributes in making this base? This base is contributed by my inguinal ligament, and medially you can see the border of my rectus abdominis muscle, and laterally I have inferior epigastric vessel, and this triangle is famous with the name of Hasselbalch triangle, and you're looking at its boundaries. Thanks for watching.